Prof.
Okay, can everybody see the slides? You guys, can you see the slides?
Yes.
Okay, great. Okay, well, welcome everybody. Good evening to everybody. And last week we talked about food and electrolyte balance, and we talked about the 6 questions that you have to ask. That is, what are the maintenance requirements? What's the fluid deficit, if any? What are the ongoing losses? What are the what's the electrolyte situation? What's the acid-base status? And the question is, what are the nutritional requirements of the patient? So this week, we're going to talk more about surgical nutritional support for surgery patients in detail. And there are a number of basic principles of perioperative nutritional support that we need to talk about. The first one is that nutrition has to be integrated into the overall management of the patient. And in many places, this is not done. We don't even consider nutritional support until very late in the management of the patient. So the first principle is, from the very beginning, as soon as we're seeing the patient, we're evaluating the patient, we have to immediately start thinking about nutrition. So we have to put that up high on our list of priorities. The second thing is, we have to avoid long periods of preoperative fasting. In fact, always we say the patient has to be NPO after midnight, and then we don't get to the case till 3 or 4 o'clock in the afternoon. But this time the guy is dehydrated. He hasn't had any food or water for almost 24 hours. He comes into the operating room. The anesthetist give him an anesthetic, and the bottom drops out of his blood pressure because he's hypovolemic to start with. So we have to think about that. The next principle is, we want to reestablish oral feedings as early as possible after surgery. Now, when I was a resident and throughout most of my career, say with colon surgery, the whole concept was that you wouldn't feed the patient until after the patient has had a bowel movement, after doing a colectomy. Well, that was incorrect thinking, and in most modern colorectal practices, oral feedings are instituted very soon after surgery. So that's a switch in thinking. And as soon as nutritional risk becomes apparent, we need to start nutritional therapy early and not wait. Okay, why is my thing not advancing here? Okay, there we go. Then obviously we're going to need to remember, after big operations, and particularly when we have a septic patient, the patients develop insulin resistance, so blood sugars can get very high. So we have to think about that. Whoops. If we have patients who are requiring postoperative ventilation, we have to minimize the amount of time they're on paralytic agents, because that will slow up their GI tract function. And also, we have to think very carefully about the use of opiates. Not that the patient shouldn't get opiates, because they clearly require pain relief, but many times patients will be on industrial strength doses, so to speak, of opiates. I remember one time I did I think it was a volvulus in a very old man, and the guy wouldn't open up, and I kept coming by, and my residents were taking care of the patients, and after about a week or so, I looked at the medication list, and I could see that he was getting these huge doses of opiates in an elderly man. As soon as I stopped the opiates, the next day he had a bowel movement, and we were able to feed him. So think about judicious use of opiates. I'm not saying that they shouldn't have pain relief. I'm just saying that many times we overdo it. And of course, early mobilization of patients is important. Now, when we are doing our preoperative assessment on patients, we should look at a nutritional risk screening. And nutritional risk screening involves 5 elements. If the patient has lost more than 5% of their body weight within the last 3 months, we've got a problem. If their BMI is less than 20 kilograms per square meter, we've got a problem. If the patient has a history of diminished food intake, we have a problem. And then we have to take into account the severity of the disease. Let's, for example, let's say we're dealing with a 40% burn. Well, this guy, by definition, from the moment we see him, is already in a profound catabolic state. This guy may need 3 or 4 times the protein requirements that from baseline. And also, a preoperative albumin is a very important screening factor. If the patient's albumin is less than 3 grams per deciliter, then we've got a problem. Now, surgery, very much like injury, because surgery is injury basically, causes an inflammatory response. And this inflammatory response causes a release of stress hormones and cytokines, which cause catabolism of glycogen, fat, and protein, release of glucose, free fatty acids, and amino acids into the circulation for the task of healing and immune response. Now, the overall consequence of all this is protein catabolism and loss of body mass, unless we replace this. Now, nutritional therapy, the definition of nutritional therapy is provision of nutrition to prevent or treat malnutrition. And we can do this in one of 3 ways: oral therapy, enteral therapy, or parenteral therapy. Now, we've talked about this before when we had the ICU course, and also in the fluid and electrolytes, our talk on fluid and electrolytes, and that is surgeons, and I include myself in this, are guilty of excess fluid administration. We all pump a lot of fluid into people. And this, and sometimes our patients need the fluid, but often we overdo it. And when this happens, this results in edema. And sometimes the patient gains several kilograms in weight, which is basically pure water. And this causes edema in the GI tract. It causes ileus, delayed gastric emptying, and therefore a delay in the ability to provide oral or enteral nutrition. Now, let's get into some details about energy sources. And it's worthwhile writing this down or even memorizing it, because when we're planning nutritional therapy, you actually, if you know these numbers, you know what you're doing. Carbohydrates yields 3.4 kilocalories per gram of carbohydrate. Fat yields 9 kilocalories per gram of fat. And protein yields 4 kilocalories per gram of protein. Why is it important to know this? Because in adult, we have baseline nutritional requirements for healthy adults. And that is to maintain health, you need somewhere between 20 and 25 kilocalories per kilogram of body weight. Of carbohydrates, approximately a little less than 1 gram per kilogram body weight of protein. And then the fluids we're not going to emphasize in this particular talk, but somewhere about 30 cc per kilogram of body weight per day of fluid. But what I want to emphasize is that we need at baseline 20 to 25 kilograms per kilogram of carbohydrate and about just a little less than a gram per kilogram of protein. So in order to be precise about that, we have to know how much carbohydrates and how much protein our patients are getting, particularly if they're not having getting oral intake. In other words, we're giving we're giving the nutrition either enterally or parenterally through the intravenously. So if we are looking at the ideal 70 kilogram adult, if the patient is if he's getting his carbohydrate requirements 20 kilograms per kilogram, 20 kilocalories per kilogram, that person's going to need 1,400 kilocalories per day just to maintain baseline. What about protein? He needs about, let's make the arithmetic easy and say he needs 1 gram of protein per kilogram. Or if he's a 70 kilogram man, the guy needs to be taking in 70 grams of protein per day. And if we're saying that the guy needs 30 cc's per kilogram per day and 70 kilograms, that means he needs to take in 2,100 cc's per day of fluids, just over 2 liters. Okay. Now, let's look at how much carbohydrate and protein is present in a liter of 5% dextrose in water. We know that there are 50 grams of glucose in a liter of 5% dextrose. So, and we also have learned that there are 3.4 kilocalories of carbohydrate per gram of glucose. So in other words, if this patient is receiving 1 liter of dextrose, 5% dextrose in water, the patient's getting a total of 170 kilocalories per liter. If our patient is getting 2,100 cc's or 2.1 liters of 5% dextrose in water per day, that means the patient is getting a total of 357 kilocalories per day. I hope you can see the arithmetic on the slides. So if we said that in the normal adult who's a 70 kilogram man, he needs at least 1,400 kilocalories per day, we know that if he's receiving 2,100 cc's of 5% dextrose in water, he's only getting 357 kilocalories a day, which is a drop in the ocean. In other words, the patient, if we think that we're giving dextrose in water and we're providing calories to the patient, that's incorrect thinking. We are not providing significant nutritional support with dextrose in water. Now, post-operative nutritional requirements are way, way above the baseline numbers that I just quoted. For example, we have wound healing. Many of our patients are septic. They present with septic abdomens, often 3 or 4 days of peritonitis before we actually see them, and many of them in a hyperdynamic state. Heart rate 130, blood pressure 80 when we first see them. So what does this mean? Just think of that your patient is running a marathon day after day after day, because that's what he's actually doing. He's running a marathon, trying to overcome this systemic inflammatory response. He's got, in many cases, they have big open wounds, which need nutrition to heal. So our patient is similar to somebody who's running a marathon, but the only problem is the marathon doesn't stop. It keeps going day after day after day. So the post-operative nutritional requirements for this 70-kilogram man is far above, as I mentioned, baseline. So for a routine, say a big operation, our patient's going to need somewhere between 30 to 40 kilocalories per kilogram per day, and almost double the caloric intake, up to 2,800 kilocalories per day. He's almost needs double the requirements of protein, 126 grams per day instead of 70 grams per day. And in addition, the patient needs fatty acids because if we only provide protein and carbohydrate supplements, after about a week or so, our patient's going to get fatty acid deficiency. Now, let me stop here for a minute, Mugisha, and see if there are any questions that we need to deal with.
Yeah, from the chat box, I see nothing. And if someone has a comment or questions, can raise up a hand and talk. Otherwise, you may continue for the next phase and see if something will come up.
Okay, very good. So there are no questions so far. Let's continue.
Yeah. Maybe Darwish, what's your comment?
Did somebody have a comment?
There's someone called Said Darwish. You can unmute and ask.
Yeah, go ahead.
He's
Said.
talking about.
Sorry, I wanted to emphasize about the body weight. I wanted to say that it is the ideal body weight calculated with the BMI. So it's like if you say a 70-kilogram male, a patient can come in edemic, weigh 70 kilograms, but calculating the ideal body weight, at what range do we take the BMI? Because we can have a patient who's obese. We're not going to give him the kilocalories for an obese patient or a patient that is in a starved state. So
Saeed, that's a very astute question. It's a fantastic question. And actually, an obese patient can be profoundly nutritionally deficient. Just because the patient is obese doesn't mean that the patient is nutritionally intact. And as you point out, somebody who comes in massively edematous or who becomes massively edematous after fluid resuscitation, just because their weight is 70 kilograms or maybe even more, doesn't mean that they're not nutritionally deficient. So your question is, if I understand it correctly, is how do we estimate the nutritional requirements when we have a massively obese patient or a patient who's edematous? And the answer to that question is you have to look at the patient's height, body surface area, and then it's basically a guess. You're wetting your finger, sticking it up in the air, and seeing which way the wind is blowing, and you have to make a guess. But just like fluid and electrolyte therapy, with nutritional support, you don't actually have to hit the center of the target. You just have to hit the side of the barn. If you're within 30 or 40% of your estimate and you start from there, you will be okay, because as you progress in your nutritional therapy, you can make adjustments as you see fit, but you have to start somewhere, as you point out. So basically, it's to answer your question, it's a guess, but as long as you're making a reasonable guess, that's a good place to start. Did I answer your question, or do you want to make any other comments?
Just one, sorry.
Go
In
ahead.
your experience, normal BMI is about 18.5 to 24.5.
That
Where do you
depends.
usually,
That depends
uh,
where you live. In certain
uh,
parts of the United States, the normal BMI is 35 because we have a massive problem in my country with obesity because everybody's eating junk food. So normally we like the BMI to be somewhere between 22 and 25. So if somebody's got a BMI of 18, according to the World Health Organization, they are nutritionally deficient. 18,
Haina tena sababu
18 is too
kuna
low, and we'll get to that because many of our African patients are nutritionally deficient before they actually get sick and we actually see them. And we have to take that into account when we're planning on nutritional therapy. Any other comments before I continue? All right, let's keep
I
going.
think you continue.
Okay. All right, so let's look, now here I made a table for you to compare
You're muted.
okay, the normal requirements are 1,400 kilocalories per day of carbohydrate. Post-operative requirements are 2,800 kilocalories per gram. And what we're actually giving the patient is 357 kilocalories of carbohydrate per day. So I just wanted to emphasize how little we were giving. And in terms of protein requirements, normally at baseline, we need 70. At post-operative, we need double that. And in dextrose and water, there's no protein whatsoever. And as Saeed alluded to, and as I mentioned, many of our patients are nutritionally depleted before surgery. So we're already starting behind the 8 ball, so to speak. In addition, there are certain key nutrients that are essential for wound healing, in particular, vitamin A, vitamin C, zinc, and various trace elements. And of course, we're not providing any of these with our fluid therapy. So who needs nutritional support? Well, anybody who's unable to take in sufficient calories and protein, that's obvious. And then we have 2 methods where we can provide nutritional support. Actually 3, one is oral, but if the guy's able to eat and we have food, that usually takes care of it itself. But if the patient is unable to take in food orally, then we have the option of providing enteral nutrition. In other words, putting the nutrition directly into the GI tract or giving it parenterally with the total parenteral nutrition or a partial parenteral nutrition. So let's look at the ways in which we can give enteral nutrition. We can give it through a nasogastric tube. We can give it through a nasojejunal tube. In other words, we can pass the tube, a tube down through the nose, through the stomach, cross the pylorus into the duodenum and proximal jejunum, and feed the patient that way. We can feed the patient through a gastrostomy tube or a jejunostomy tube. Now, I just want to talk about a nasojejunal tube for a minute. We use this a lot in the United States. This is a thin, very flexible tube. Excuse me. This is a thin, very flexible tube, but you have to have commercial feedings which are not viscous, which can easily flow through this tube because it's a long, narrow tube and it's got a lot of resistance to flow. And we often put it on a pump to pump the nutrition into the patient at a rate somewhere around 50 cc's an hour or so. Most of the places that I have worked in Africa do not have this this technology available. Maybe later on we can hear whether you guys have this or not. My guess is that most of you don't have this tube. If we have an NG tube in, and the stomach and the GI tract is working, we can easily feed the patient into the stomach. We have to be careful about the risk of aspiration. And then we can, if we have a gastrostomy tube in or a jejunostomy tube, we can use that. And I just want to say, I can't remember whether I got another slide later on about this, but I'll just give you my own personal prejudices, and then we can see what you guys think. Personally, if the stomach works and is present, I personally prefer a gastrostomy tube. And many times, I'll put a tube in the stomach as a gastrostomy to decompress the stomach if it needs it, and I'll put a second tube through the same hole and pass that across the duodenum into the jejunum, or sometimes even across a gastrojejunostomy and anastomosis, and placed it in the distal limb of the jejunum so that I can begin early enteral feedings. I personally prefer enteral feedings, whether it's going into the stomach or the jejunum via gastrostomy tube, for two reasons. One is that if you hang up a jejunum and fix it to the anterior abdominal wall, sometimes that can act as a focus for a bowel obstruction. So if you use the gastrostomy tube, the risk of a bowel obstruction is very, very, very small. If you put a jejunostomy tube in, I don't know exactly what the risk is, but it's higher, and I've seen several cases of small bowel obstruction from jejunostomy tubes. That's number one. Number two, the second reason I prefer it is the stomach wall is thick. You can really get a good bite of the stomach and tack it up to the anterior abdominal wall. And personally, when I'm doing a jejunostomy or a gastrostomy, I consider that like an anastomosis, that you really have to do a good job of fixing that, so that there's no possibility that either the tube feedings or the intestinal content is going to leak out around the hole between the abdominal wall and the viscus. But sometimes you don't have a stomach if you're doing a esophageal gastrectomy, or for another reason it's unwise to use the stomach. So in that case, a jejunostomy tube is perfectly fine. And I might say, I just want to, for full disclosure, these are my personal opinions. I have friends who disagree with me and think that a jejunostomy is a great way to do it, but we have a friendly disagreement about that. So you can make up your own mind. I'm just giving you my personal views based on my experience. So the other option, if for whatever reason so enteral nutrition, feeding via the GI tract, is the absolute preferred way of doing it if possible. But of course, in many of our patients, at least initially, we can't use the GI tract for one reason or another. And if that's the case, we have to consider parenteral nutrition. And parenteral nutrition can be, of course, given by the subclavian vein, the internal jugular vein, or more recently, not by more recently, I mean in the last 20 or 25 years, PICC lines are used. These are peripherally inserted central catheters, and they're often they often have to be inserted with ultrasound guidance to access deep veins, because many of our patients don't have good peripheral veins. And in my hospital, we have a special team of nurses that are trained to insert these lines, and they're actually quite good at ultrasound. And they feed these lines in from the arm rather than using the subclavian vein or the internal jugular vein. And of course, that eliminates a lot of potential technical complications. So let's move on then. So the indications for nutritional support are, inability to eat for 5 to 7 days after surgery, major burn or trauma, in other words, basically patients with large wounds, septic patients, or patients who have short bowel syndrome, which is another issue and not really the subject of today's talk. Now, what about the contraindications to enteral feeding? In other words, when should we delay enteral feedings? Well, obviously, if the guy is expected, let's say you do a routine appendectomy, the appendix comes out, the patient's going to be starting to eat very shortly after surgery. Well, that's not somebody that we need to consider enteral nutrition. If the patient has a intestinal obstruction or an ileus, then that's a contraindication to enteral feeding. If our patient is in severe shock, well, first of all, we need to stop the bleeding, stabilize the patient. So enteral feeding is not really the issue. On the other hand, we have to be thinking about it, because as soon as we get control of the hemodynamics, then and the patient stabilizes, then we should begin it. But right in the midst of battle, that's not the time to start enteral feedings. If we have a patient with intestinal ischemia, this is not the time to start enteral feedings. If we have a patient with a high output fistula, then giving enteral feedings proximal to the fistula is not a great idea, because it's all going to come out the fistula. On the other hand, on occasion, we can slip a catheter through the fistula and thread it down into the distal bowel. And sometimes, if we're having a very good day, we can actually provide enteral nutrition into the distal bowel through the fistula tract. Not, in my experience, that hasn't happened very often, but sometimes it's possible. If we've got a guy with severe GI bleeding, now's not the time to start enteral nutrition. And then occasionally, we'll have a patient who's receiving palliative care. In other words, a patient who is not expected to survive, and our goals of treatment have changed, so that we're not trying to rescue the patient anymore. We're trying to ease the transition into the next life, so to speak. And in this case, we might want to allow the patient to drink or even eat a little bit if that's going to make them feel better, but we're certainly not going to start parenteral nutrition in a patient like that, because that's a waste of resources and it's not going to help the patient. So those are the contraindications. All right. Well, I've already discussed this, but my view is, if the stomach empties, use it. In other words, we prefer using the stomach if at all possible. And I already gave you my prejudices that I prefer a gastrostomy tube to a jejunostomy tube. But if we don't have a stomach, or if it's not functional, then I use a jejunostomy tube. But that's me. You may have another opinion. And actually, why don't we stop now? Because we have a lot of experienced people on this call as well. And does anybody have a different view than the one I expressed? Does anybody prefer jejunostomy tubes to gastrostomy tubes? Do you think I exaggerate this? And in full disclosure, I have many friends who think I am exaggerating this a bit. Anybody want to make any comments? Mugisha, do you want to? Now, can you guys hear me? Can somebody respond?
Yes,
you can hear me. All right. So it sounds like there are no comments. Is that right?
There is one question. The one a colleague is asking about the daily fat requirement, because we just heard about the daily carbs and protein requirement. Do you have any comment on that?
Right. So there is if we're having long-term nutritional support parenterally, that is by the intravenously, you have to provide some of the calories as fat, as a general. When you look up the formulas, it tells you how much fat you can provide, but really, as long as you're providing fat on a weekly basis, that's okay. You don't have to provide fat every day. However, many of the TPN protocols do provide it. The other way you can provide fat is the short chain fatty acids, which are absorbed in the duodenum and proximal jejunum. So if you give some fatty, if you have this capability in your pharmacy to get some short chain fatty acids, that's a very good way of making sure you don't get fatty acid deficiency. If you don't have that, and if the patient's requiring total parenteral nutrition, the formulas have free fatty acid. And to be honest with you, I don't remember exactly what how much fat is included in those formulas. It's easy to look up on the internet. I just don't happen to remember that at the moment. Does anybody else on the call have any information to share about exactly how much free fatty acids have to be provided per day in hyperalimentation? Anybody know the answer to that question? Ali, do you happen to know the answer? Okay, sounds like everybody else is just as ignorant as I am on that. I'm sorry, I can't give you a better answer than that. But the bottom line is, if you're providing some fatty acids each week, that will take care of it. Any other questions? All right.
Yes, there is another question on the chat box, and this is from Francis, and they say he thinks, in his experience, in his setting, he normally don't go for jejunostomy because there is a lack of the specific feeds that you need to provide when you are putting jejunostomy. That's why the gastrostomy or gastric feeding tubes is indicated more than GFT.
Okay, I think that's a great comment, and one of the issues is the type of tube you're using and the type of nutrition. For example, when I first started working in Tanzania, the nutrition that was given was porridge, and you can't get the porridge to flow through these tubes, and the tubes would plug up all the time. So, and then many times, at least in the hospitals that I've worked in, they didn't have the commercial enteral feedings that we have in high-income countries. I don't know whether that's changed or not, because I haven't been to Africa for 2 years because of the pandemic. But I would say this, that if in your environment, you don't have access to commercial enteral feedings, and for whatever reason, you're not able to provide good enteral feedings because of the problem of plugging up the tubes, these feeding tubes, if they're in the stomach or in the jejunum. This is a problem, and problems are made to be solved. So what I would suggest is that you look at your environment. Are you having a problem with surgical nutrition? Yes or no? If you're not having a problem, then you move on to other problems. But if you're having a problem, you can't do big surgery, or you can't rescue critically ill patients if you can't feed them, because they're going to die. So if you have a problem, put together a small team of 3 or 4 people and give it a time and make a timeline and say, okay, we need to solve this problem within 3 months. And maybe you need to have an administrator on the team too, and just look at what the problem is. So what my thought was, and I don't know whether this is a correct thought or not, patients need protein and calories. And if everything's plugging up, and I have a patient who's got a fistula, for example, who needs enteral nutrition or some big burn or something that needs to be tube fed from the very beginning, and I don't have the feedings, go out and buy a goat. I don't know. I don't even know if this is a reasonable thing. Go out and buy a goat, barbecue the goat or whatever, blenderize it, and make up your own protein formula and put enough liquid in it so it's dilute, so that the tube is not going to plug up. Now I don't know whether this is even a reasonable solution or not. But I'm just saying problems are made to be solved, and if you get a team together, give them the job and have them solve the problem. Give them a timeline. We need this problem to be solved in 3 months. I don't think that this is not rocket science. I don't think this is an overwhelming problem that's going to take a long time to solve. It just needs a couple of smart people sitting in the room, putting together the ideas, and then effecting it. There's this concept of thought, speech, and action. And a lot of times we go to meetings, we're having a lot of thought, a lot of talking, but nothing happens. So thought and speech are okay, but they're irrelevant unless there's an action taken. So I would just say that if you're unhappy with the nutritional support and you don't have the resources, either figure out a way to get the resources or use the local resources to solve the problem. Anybody want to respond to that suggestion?
I think it's a relevant point, and we can't over-insist because the future requires us to have those particular pre-prepared materials, food materials to feed our patients that not depend on porridge and banana porridge as a part of supplements for our patients in African setting. So I think it's very relevant, and it's a challenge to young people, young surgeons, to go ahead and forge the way. We talk with the stakeholders and persuade them until this comes to be a normal provision and supported by NHIF or funding for the patient to have adequate nutrition. I see Dr. Eva Sanga has a hand too. So maybe go ahead and make some comments on that.
Dr. Sanga, go ahead. I think, Dr. Sanga, you might be on mute.
Hello?
Now we can hear you. Go ahead.
Yes, thank you for a chance to contribute. Yeah, from my experience on what I used to do is I try to find means to mix the same porridge with something else. They take a boiled egg and they grind the yolk, and they leave the remaining, the egg white, and mix it in a porridge, and then they put milk. So the food will have protein, will have the carbohydrate, and as well they can put maybe a bit of ground nut as well, and grind them all together. It's so difficult to get the required kilocalories and measure the content, because depends the size of the tube, depends the speed of the flow, then the clogging. So you might need a lot of volumes, and we know these patients, they don't need a lot of volume sometimes, which will be so detrimental in critical care. So to do that one, sometimes they advise to have a special prepared diet, which are now available in our market. We have a lot nowadays, like Ensure, like Groviva, Max Vida, Vidavance. These are really calculated content with vitamins, minerals, protein, and carbohydrate in kilocalories. That if you take 30 grams, that is 2 scoops, is about 450 kilocalories. So you can calculate the daily kilocalories required, and you know how many scoops the patient will require in the whole day, mixing it in a fluid according to calculated requirement volume of that day. Then if you mix those scoops in that volume, you keep feeding maybe 3 hours, every 3 hourly, and then you achieve your daily kilocalories. And it's cheaper. For me, I think it's cheaper because it's very expensive for the relatives to travel to the hospital and off and preparing everything diet. And the price of the tea is quite cheap. I mean, if you compare the food they put for the whole week and that thing, is cheaper. So I advise people to do that. And I've seen the outcome is quite good in most of the patients in ICU. So that has been my approach. And to do that as well, I've been topping up, trying to prevent maybe refeeding syndrome for some of the patients, surgical patients who have stayed for quite a long fasted, and they were on carbohydrates, say D5, DNS, prior they being referred to my unit. So I usually be cautious at my first initial meal starting point. Then later, I've seen some refeeding syndromes. So later I catch up to the required 280 kilocalories from 400 kilocalories per day. Thank you.
Well, that was an absolutely fantastic comment, and I think you made 2 very important points. One is I didn't realize that you can actually now get Ensure and some of the other commercial feedings at a reasonable price. I don't know if it's available all over, but if you can get that, it tells you exactly, as you pointed out, how many carbohydrates, how many grams of protein, etc., are in these things, and so that you will have a very precise knowledge of exactly what you're putting into the patient, so you can compare your estimated caloric requirements with the amount of calories that you're actually giving. Also, your idea of if you don't have that available, your idea of using eggs as a source of protein, I think, is a fantastic idea. I'm sorry I didn't think of it myself. That'd be a great way of adding protein. I think if you're using the thick porridge that I'm familiar with, that's almost a guarantee to plug up most of the tubes that we use, and there's got to be some other way of diluting it so that the tubes don't plug up. Anybody have any tricks to keep the tubes open that we can benefit from?
Yes. The tubes tend to clog every time and then, especially when you use high fat diety or high proteinous diety, or when you're using the tubes for feeding and not well blended materials. So every time and then that I try my level best, I use Coca-Cola. You take it in a syringe and then you plug in a clogged tube, and many times it tend to lyse all the clogging materials. I learned this experience from 10 colleagues who use Coca-Cola to clear the esophageal stent that they have put to the patient who has esophageal CA. So that's my trick. I don't know if others have.
Well,
sometimes hot water.
That's a fantastic trick. And I don't know if this is true or not, but there's a legend in America that if you put a spoon in Coca-Cola and leave it overnight, part of the spoon will dissolve. Well, that's true. Whether that's true or not, I don't know, but but it speaks to your trick of using Coca-Cola to open up clogged tubes. I like that. Anybody else have any other tricks? All right, well, let's continue then. So the steps for enteral feeding is do your best to determine what you think the caloric, protein, and fluid requirements are. Well, obviously you're going to determine the fluid requirements, but in addition, question number 6, what are the nutritional requirements? Calculate the caloric and protein requirements. We know that we have to give some degree of fat per week, and unfortunately, I gave an inadequate answer to the question that was posed. I'll have to look that up after I finish this talk. That was a great question, but we can probably find the answer pretty easily on the internet. And you can select your enteral feeding formula, or you can make up your own feeding formula, as we just discussed. And I really like the idea of mixing eggs up with the whatever other stuff you're putting in there, such as porridge. And then now we have found over the last 35 years or so that putting the enteral feedings on a pump, an electronic pump, just like an IV, where we pump the fluid in at a certain rate, is very helpful, because instead of giving the patient a bolus, which sometimes when you give bolus feedings, they get distended and they have difficulty with it. If you give it at a slow, continuous rate, it's better. Now, I recognize that, number one, you may not have the pumps. Number two, unless you're using a commercial formula, you may not be able, the pump may not be strong enough to get the porridge through. But somehow try to have some concept of how many calories and how many grams of protein you're given per day, and comparing that with the patient's requirements that you've calculated. All right, now we've talked about this, but one, and I alluded to this before, but if you're having problems in whatever area, if you create a small team to solve the problem, that's going to be very effective. And I'll tell you, you know, at the Massachusetts General Hospital in Boston, which is one of the great hospitals in the world, there was a guy named Edward Churchill, who was the chair of surgery during the 1930s and 1940s. And he looked at various type of problems that they were having. For at that time, they were trying to work out parathyroid surgery. So he took one guy and assigned him the problem of figure out parathyroid surgery. And the guy went to the autopsy lab and did maybe 70 dissections of the parathyroid gland. Nobody even knew how to find them at that time. Same thing with, if there were problems in thoracic surgery, he would assign another guy to deal with that. So each problem where they were underperforming for whatever reason, he would assign one person or a small team to try to solve the problem. Nutritional support is a relatively easy problem to solve. We just need to recognize it as a problem, assign people to do it, and give them a deadline, because we're not trying to find the cure of cancer here. We're just trying to figure out how to get nutrition into a patient. It doesn't seem that it's that difficult a problem to solve. All right. Now, what about parenteral nutrition? Well, it's the same thing. If the guy is not going to be able to eat, and there's a contraindication to enteral nutrition, we've already discussed those, or you've tried enteral nutrition, and for whatever reason, the patient is not able to tolerate enteral nutrition. Now you have to think about parenteral nutrition. And there are two types. There's total parenteral nutrition and peripheral parenteral nutrition. So if we talk about peripheral parenteral nutrition for a minute, it's lower osmolality. You can give it by a peripheral vein, although phlebitis remains a potential problem. But since it's less concentrated, you have to give more volume to deliver the same caloric and protein requirements. On the other hand, if you're using total parenteral nutrition, you're using high glucose. Somebody have a question, or they just are not muted?
No questions. Go ahead. I'm trying to mute.
Maybe we can mute them. So then you're using high glucose concentration, somewhere between D15 and D25, you got a very high osmolality. So therefore, the fluid needs to be administered by a central line. And of course, there are all sorts of technical problems related to subclavian catheterization, internal jugular vein catheterization, pneumothorax. Sometimes the line can be placed in the pleural space, and then you're actually putting your fluid into the pleural space. I've seen that happen on a number of occasions. So you have to be careful. But in terms of writing your TPN orders, you have to determine your total fluid requirements. You can determine your total caloric requirements, and you give 70 to 80% of them as non-protein caloric requirements. Determine the fatty acid caloric requirements. And somebody asked this question, and I gave an inadequate answer, so we'll have to I'll have to fix this slide and look up the answer to that. But according to this recommendation, 20 to 30% of the non-protein caloric requirements should be given as fatty acid. And then determine what your protein requirements are, which of course are given by amino acids. And then obviously determine the electrolyte and acid-base status and adjust the fluid accordingly. When you're starting TPN initially, you have to monitor the electrolytes daily. Because if you're giving high concentration of glucose, you have to monitor the glucose initially every 6 hours, and then add insulin as required. When you're giving TPN, you have to check the triglyceride levels frequently, and you have to stop the lipid infusion if the triglycerides are high. I remember one patient in our ICU was getting sort of got overdosed on lipids, and he actually got pancreatitis as a separate issue from his underlying illness because of the hypertriglyceridemia. Somebody screwed up and stopped checking the triglyceride levels. You have to check liver function tests, and you should check the prealbumin level. The goal is to get a normal prealbumin level between 18 and 25 milligrams per deciliter. And remember that patients on TPN are at risk for a metabolic acidosis. You may have to adjust the chloride with acetate to maintain acid-base and electrolyte balance. In other words, there's a lot of chloride in TPN. If the patient's getting a hyperchloremic metabolic acidosis, you may have to replace some of the sodium chloride with sodium acetate. That's the bottom line there. Now, there are metabolic complications. You get liver problem, metabolic acidosis. You have to provide essential elements like copper, zinc, etc. Otherwise, you can get various rashes because of this essential element deficiency. You get vitamin deficiencies unless you add vitamins, and then you can have technical problems like line sepsis, central venous thrombosis, pneumothorax, etc. So in summary, know what your patient's daily caloric and protein requirements are. Know how many calories and grams of protein your patient's receiving each day, and make sure the intake of calories and protein, carbohydrate and protein, matches the patient's requirements that you assessed. And this is a wonderful article that I found, which gives you guidelines for clinical nutrition. The top part over here is the reference. Wyman and all. It's entitled Clinical Nutrition's ESPN Guidelines, Clinical Nutrition Surgery, and it's in the journal Clinical Nutrition, published in 2017. And this is the website where you can get it and download this article. It's a very easy to read, very well referenced, and it gives you a series of guidelines which can help you if you are having a problem with nutrition and you want to establish a small nutritional support service. It'll help you sort things out. So with that, ladies and gentlemen, that completes my presentation, and we'll open it up for further discussion. Mugisha, why don't you take over, okay?
Thank you very much, Prof. And indeed, it has been a very enlightening moment, and the points that you have shared with us are very critical. Yes, Dr. Sanga wanted to speak again, but let me also pose these questions. When do you start feeding your patient post-operatively? What are the recommendations? That's all the questions in the chat box. If you feel you have a comment, you can raise a hand. I can give you a chance, or you can unmute and start talking, or you can write in the chat box. We have almost 20 minutes for discussions, so don't worry, take your time. Just be brief and hit the point. Thank you. Karibu. Dr. Sanga, go ahead.
Thank you. Sorry, Mugisha. What was the question?
The question
when do you start feeding your, let's say you do a colectomy, Dr. Sanga. When do you start feeding your colectomy patients?
Okay, thank you. Prof and the team, from most of the studies, especially from the studies pertaining any surgery involve the bowels, they say as early feeding really promotes good recovery for this patient. And we have seen some of the patients in some of the country, as soon as they're out of theater, they can just started this ready-made, ready-prepared nutrition diet with the infusion with the pumps you are mentioning for slowly feeding, and the patient really improves. Now, that's my recommendation is as early as possible, because any delayment, initiation of food will cause a lot of refeeding syndromes, and guts will be so edematous, and we know they get villus atrophy. If we don't feed them as early as possible, they might have succumb a lot of problems. Then the refeeding will be so difficult with a lot of malabsorption. So I prefer as early as possible. That's for the idea of which was plan of my general comment. For the idea of to get the infusion in Africa, it's difficult. But I had another idea. We're using the urine bags. You cut a urine bag inside and remove the valve. You fill in your whatever porridge, ready-made food, any Maxvida powder inside with the volume required. You connect a giving set or giving line, which you can control the drops. Then you allow it to go slowly. Clogging is so difficult in that matter, because most of the time it's flowing all the time. It's flowing. Over inflating of the gastric, of the stomach, is rarely because you're going slowly. So you don't overfilling it. There's no disturbance of the diaphragm, no hiccups, and as well as less risk of aspiration. So if you do that, it's a good idea, and to go slowly. Another thing is for the critical patient, we usually need to check a residual for those who are feeding intermittent boluses, small boluses, maybe of 400 or 300 every 3 hours. You have to aspirate before feeding the another feed to see the residual, sorry, to see the residual fluid, residual content in the abdomen, so that you can recalculate the next feed. That's what that's my experience in ICU as I deal with nutrition issues. And the final general comment after leaving that question is that most of our patients, they are highly in malnutrition side, as professors just said, and now they are succumb a lot of fasting hours before the procedure, on tubes, on different drainage. Then they went to the surgery, then they're out. So I find another wonder drug in ICU could be FFP. FFP has a content of albumin and protein. You know, for this patient to assimilate your protein you are feeding from the from the egg
Carol.
or from the porridge, making up enough, diaminating it and making adequate protein, essential amino acids, disaster. That's why we need to feed them a ready-made nutritional diet. Then you don't have that one. FFP has been a wonder drug of adding albumin in this kind of patient, and has very good outcome, reduce the bowel edema, then there's good assimilation and absorption of food in the gut. So I usually start with FFP. I feed them like, not feed them. I infuse them like 2 units or 3 units, maybe, and assess them. They usually respond well. Thank you.
Thank you for your comment. I want to just talk about one other thing that you mentioned previously, and that is refeeding syndromes. And emphasize that if you have a profoundly nutritionally deficient patient that comes to you, you want to start the feedings very, very slowly. And it sounds like you've had some experience with that. Do you want to comment on make any comments on refeeding syndromes, or does anybody else want to make a comment on that?
Yeah, thank you, Professor. I've met this kind of patient because they have really long fasting hours, and they've been in high dextrose containing fluids before coming into ICU. I usually go slow with we know the daily requirement is from 1,400 for normal, and abnormal is 280. But I usually start with quarter to 1/3 of the required kilocalories per day. And the feedings are really spaced if they're intermittent bolus. Instead of 3 hours, I usually do to 4 to 5 hours between the meals. And I'm really careful to aspirate before feeding any other feed for the gastric to see if there's a good gut motility. Because any residual above 50%, or if I feed 200, then I come to aspirate after 4 hours, 200 means there's poor gut motility. Then I either withhold or reduce the volume, and then plan another feeding. So with that one as well, I'm usually careful in nutrition in that way. So I usually start with quarter to a half of the required kilocalories in first 1 day to 2 days, then to the maximum required kilocalories, maybe it's 2,000, for the 70 kg, maybe 2,800 kilocalories per day to avoid refeeding. I'm careful in electrolytes because that's the way we can detect it. I'm so careful in assessing the electrolytes, and especially for the patients who have been given TPN, either peripheral or central TPN. Nurses, they forget themselves giving all the 1,440 ml of TPN and run it as quick as possible. I usually prefer to go slowly to 24 hours, 48 hours, but they can finish it in 1 hour. So the patient is hyperglycemic, hypermagnesemia, hyperlipidemia, everything goes hyperphosphatemia. They have this kind of a lot of deranged electrolytes. Then they change to something else. So keen to give the TPN slow. If the kilocalories required is 2,800, I usually start with either quarter to a half, and I usually assess how severe the patient are. Age, like patient who are with tumors, patient with old age, patient with a severe malnutrition. This one I'm really careful to go slow to 3 days.
Well, thank you very much for your comment. I think there's another important point that Dr. Sangha mentioned, and that is checking for residuals. Because when you're giving enteral nutrition and you're not paying attention, you can, and the patient is not emptying the stomach, they can vomit and aspirate, and that can turn out to be an absolute catastrophe. So you have to remember to check the residuals to make sure you're not over distending the stomach and then causing an aspiration, which can end up as a catastrophe. Any other comments?
Yes, I want to make a comment. And this is general comment from what was spoken and with my experience. I am the believer of enhanced recovery, or we call it ERAS, quick recovery. So nutrition is important part and parcel of enhancing patient recovery post-operatively. And I consider nutrition as part of my plan even before putting the patient on the surgical schedule or list for the next day. At least you have a plan in your head on how best you're going to feed and what are the time that you need to stop the patient post-operatively, how many days. And this comes into in line with, come to same line with when do you start feeding the patient post-operatively. And if you have thought appropriately, you'll find that this is can be decided just case by case and surgery by surgery. For example, you are having a child whom you are going to close up the umbilical hernia, and the child has starved almost for 6 hours preoperatively. Just immediate after surgery, if the surgery was completely well, no intraoperative complications that require this patient not to be fed, I regularly recommend early feeding immediately when the child is fully awake, start feeds as much as can tolerate. For like thyroidectomy patient who has no issues with airway, I start the patient immediately. For the bowel procedure, it depends which type of intestine, which type of surgery did I do. If I just did an enterotomy and closed up, then feeding will be immediate. Even with anastomosis, day 2, day 3, we'll have resumed some feeding. And I recommend that we tend to use, there is a study, my colleagues from Tenwick Hospital in Kenya, they did a study on the use of bubble gum to stimulate ileus, to stimulate bowel functioning, resumption of bowel functioning. So you can start the patient postoperatively. If you did a colectomy, give a bubble gum or a chewing gum, they start stimulating the bowel, and it will help enhance the recovery or quick recovery of the patient. But you have really put it very nicely, and it should be our concern as surgeons as we plan our patients. Another thing that I want to comment it is the time, the required preoperative fasting that our colleagues in anesthesia do require. You may find tomorrow, as Friday, having 3 patients to operate. One will operate at 8, another one will operate maybe at 10, and another one will operate maybe at 12 or 1. But you'll find that all of these patients have been put to the same schedule of fasting. They all fast from 10 a.m. or from midnight, while you could have titrate your recommendation, this fast at this particular hour, and they achieve the same hours that anesthesia always require to avoid risk of aspiration. So those are my few comments. Thank you.
Okay. Any other comments or questions?
Edward, go ahead.
Okay, thank you, Professor and Tankoro. Your comments are actually, I was following up on your comment based on the timing of initiation of enteral feeding. And this is actually in line with Cochrane review of 2016 regarding when to initiate enteral feeding in lower GI surgeries. And the outcome of interest were actually a day of hospital stay, as well as a risk of anastomotic leak and other comorbidities post-operatively. So actually, the meta-analysis, which was actually a global, centered, had a suggestion similar to what you have said, that the enteral feeding should be within 24 hours post the lower GI surgery. And I think we also have to move on when to what parameters should we consider before we have initiated the patient on the oral feeding, especially the common, which I didn't find anywhere. I think it's most common in our practice that we refer to regaining of bowel movements, especially the bowel sounds, to when we have to initiate the enteral feeding. But in this, in some papers I've recommended now, post-operative, the gauge reflex should only be the only parameter to monitor, because we have to worry of a risk of aspiration for these patients post-surgery. So better we use a gauge reflex. Whenever the gauge reflex is regained, this patient should be initiated the enteral feeding. But as Dr. Nkoro have said, that maybe we have to also discuss on which type of feedings we have to give first, because most of the time we recommend that the patient should start a plain tea or black tea. Maybe this is actually containing solely of maybe carbs with no protein or amino acids. Professor have said should be one of the component. Is it a rational, or we should also rethink on which festive food to be given to this patient? That's only comments I have.
Yeah, well, thank you, Edward. Those were great comments. My son is a very, very busy surgeon now. I passed the torch to him, so to speak. And he routinely sends his colectomy patients home on post-op day number 2 or 3, not necessarily waiting for a bowel movement. And I think your comment about that the gag reflex is intact, they can protect their airway, they can start with sips. I know that black tea is in many parts of Africa is the standard initial post-operative treatment. We do something called clear liquid here in the United States, but I'm not sure it's totally rational. And in most cases, it doesn't make a difference, but certainly, I think something with a little more nutrition is warranted in my opinion. Of course, if the patient's going to start, if you anticipate that the patient's going to be eating within 5 days, it really doesn't matter what you give them as long as you're stimulating their gut to work and getting them up and moving around so they can have the enhanced recovery, as Dr. Mugisha alluded to. So, but I think that we all have these traditions that we learned from our teachers that were based on their experience, in quotation marks. And some of the things that I'm telling you based on my experience may not be correct. So I think you should take what I'm saying and take it with a grain of salt, compare it with your own experience, decide whether or not you agree or disagree, and then move forward. The purpose of these lectures is not only to inform, but just to stimulate you to look at your own practice and see whether you're happy with what you're doing, and if not, to consider how to make changes. Any other comments or questions?
There is a question about the use of PPI to reduce stress ulcers. And the colleague is asking about superiority and effectiveness between ranitidine, which is an antihistamine, and PPI like pantoprazole. Based on your experience, what could be your comment? Which one should be effective or is effective?
All right, I've used all of them. I can't. I would say I personally like protein pump inhibitors, but if you look, remember I started doing this over 50 years ago. So over 50 years ago, we were routinely in the ICU seeing GI bleeders, routinely seeing stress ulcers, which would perforate. In burns, they call them Curling's ulcers. And now you almost never see them. And I think the reason is that we are using protein pump inhibitors. That's the advantage. On the other hand, we know that patients aspirate around their endotracheal tube cups, even though we think they don't. They do, and the stuff coming up from the stomach when you use protein pump inhibitors has more bacteria in it than if it's the acidity of the stomach was the pH of the stomach was lower. So you have to balance risk of pneumonia related to routine aspiration of stuff. But overall, I think personally that some type of ulcer prophylaxis has been in my lifetime. I've seen a tremendous change in the complications from stress ulceration. Whether ranitidine is better than PPIs, I'll be honest with you, I don't know. I'd have to go to the literature, and I'm sure there are randomized controlled trials I just don't know what they are. But I can just say that I personally use protein pump inhibitors. Does anybody else have a better answer than that based on your experience?
I think it's a question of availability many times. To me, PPI is more available than antihistamine ranitidine. So I always put my patients on omeprazole or pantoprazole IV. And I've seen some other colleagues giving ranitidine. It's okay, but I don't come across with literature comparing the two. If someone else within this audience has some experiences, he's welcome to share. But also wanted to respond to Dr. Edward about routine start of clear fluids sips like black tea, which is, I don't even think if it has some carbohydrate, it's just warm water with a certain concoction of tea leaves or something like that. It's just a philosophy, or why are you doing so? In the past, it was the best way to start when you don't have a lot of things to test and avoiding refeeding syndrome. But I think now it should be individualized, patient to patient. There are patients that need to start on full diet. For example, you have just resected an abdominal wall tumor. You have nothing to do with keeping the patient nil paoro for a couple of days. You have taken out the hemorrhoid. The patient should start feeding immediately so that can regain function. And we should think of individualizing our patients. We always treat them the same, regardless of their requirement. And this brings a point of a nutritional assessment before surgery. If you don't think of nutritional assessment before surgery, it's likely that you are not going to address it immediately after surgery. Thank you.
Any other comments or questions?
If you have, please comment, because we are almost on time or in time. So maybe you make your closing remarks, Dr. Bill, and tell us what we are doing next week.
Well, I learned a lot from the colleagues who made comments based on their experience. I hope that this has been an interesting presentation. I think the discussion was very interesting, and I appreciate everybody participating. And it looks like we have 49 participants, so I appreciate everybody devoting your time this evening to participating in this seminar, and we'll see you next week. So thank you all very much.
So what are we doing next week?
The question is whether you want to go over and do another session on making rounds, or we can. I'll have to. I actually haven't given the thought about that. We can look into. I'll look and send you certain topics, and
Okay.
we can decide.
Thank you.
We'll let you all know within 24, 48 hours what the topic is for next week.
Yeah. Okay. Thank you. These are closing remarks from the moderator and organizers. We want to thank every one of you who have found time and participate in this particular tutorial. All senior doctors and junior colleagues and residents all over across the continent, they have participated in this meeting, and we think that it has been a very useful moment to stay with us for the past 90 minutes. We have a couple of announcements to make. Next week, again on Thursday, we will have a talk. We dedicate every Thursday as evenings for surgery and surgical education. So please hang around, look for the link, and I'll be sharing the link as soon as I get the discussion for the topic to discuss next week. And we are calling all of you, if you are interested, to have the a copy of the learning material on the video for this conference. I'll share them. If I have your email, you can write to my WhatsApp, or you can write to the info@netcarefoundation.com. You can write, and I'll easily send you the link. The last but not least, we are also planning to, I've started registering that we are official CPD providers so that we can be issuing certificate for those who have attended and claim the CPD points for their next approval or use in renewing their licenses. So maybe from next week, we'll have some updates and we maybe starting issuing some CPD points so that it become very much useful. Wish you all good evening, and take note that the conference is about is around the corner. On 27th to 29th in Moshi, we'll be having a surgical conference, and we'll be talking of featuring issues related to coping with complications. Until next time, we wish you all the best. Thank you. Thank you, Bill.
Okay, Mugisha, thank you very much. And we'll see you next week.